Hi, good morning, everybody. Um, so I'm going to be talking about a case we did last week on this. This was presented at the conference a few weeks back. So this is a 68-year-old female.
Hey, Rob, we can't hear you.
Oh. Hello? That's weird.
Hello.
Hello? You guys can hear me?
Yeah.
Yeah, we can hear you now.
All right. So this is a 68-year-old female presented with chronic back pain, history of a 4-5 ALIF in 2019 at outside institution. She had an attempted ALIF prior to that had where she basically had cardiac arrest during the exposure. She has a history of cerebral palsy and depression and anxiety as well. So she basically presented with chronic back pain, stooped forward gait, and generalized weakness in the lower extremities mostly, and stiffness as well due to her cerebral palsy. These are her x-rays, standing plane films showing this coronal plane deformity in the lumbar spine. And let me pull up her sagittal parameters. PIL mismatch was 22.3 degrees. She had a pelvic incidence of 80, and again, showing the coronal plane deformity and malalignment, coronal imbalance. The interesting thing, so her deformity was relatively flexible on supine films. Her coronal deformity corrected quite nicely. MRIs, I'm not going to go through. Nothing all that interesting. Her DEXA showed borderline osteopenia. She also had a SPEC CT, which showed 2-3 increased uptake and some uptake at the prior 4-5 fusion. So we ultimately, ultimately decided to correct her deformity with a circumferential, minimally invasive approach with a 5-1 ALIF, 2-3 and 3-4 lateral interbody fusions, 3-position surgery, and ultimately we're able to achieve good stabilization of her deformity and sagittal alignment. These are her standing films showing the correction of the mismatch and her coronal plane fixation. So this case, along with another case that we saw in clinic, really got me thinking about MIS deformity correction and the circumferential deformity, minimally invasive deformity technique. So I just thought I would use it as a springboard to talk about that, these issues. So as we know, adult spinal deformity affects approximately 60% of elderly patients and can be associated with significant morbidity, specifically sagittal imbalance, PIL mismatch correlate with a lower quality of life and pain. Open correction techniques are associated with longer incisions, more muscle damage, big osteotomies, blood loss, and these can be challenging surgeries to withstand for patients that are elderly or kind of more fragile. MIS has been sort of shown to be an alternative with comparable surgical outcomes and lower complications. So just getting into the literature a little bit, this is a paper by the ISSG and Dr. Uribe showing MIS versus hybrid versus open, and particularly looking at the blood loss, 669 cc's of blood loss versus almost 2 liters in the open group. No intraoperative complications were reported in the MIS group, and then 30% complication, postoperative complication versus 50% in the open, and then in terms of major complications, 30% in the MIS versus 63% in the open. So significantly decreased complication rates in the MIS approach. This is a paper that Dr. Mundis wrote along with Dr. Barnia which was an early review of minimally invasive deformity correction. And again, it's consistent with some of the other literature that I'm going to discuss, but showing that ODI and pain scores and SRS scores are all comparable or improved with MIS techniques, and the complication rates are relatively low. MIS showed low neurologic complications and as well as lower blood loss, as I mentioned before. In terms of circumferential deformity correction, what we did, this paper by Neil Anand, that again showed decreased blood loss and deformity correction, showed effective deformity correction can be achieved with MIS, circumferential MIS techniques. So this is a case, just another example of a case that I did with Dr. Eslack early on in the fellowship back in early August, and patient had significant degenerative scoliosis and sagittal malalignment. We used the same circumferential approach with an ALIF at 5.1 and then multiple lateral interbody fusions. We're able to achieve good decompression of his significant asymmetric collapse, which was causing him a lot of neurologic problems, particularly on the right side. You can see the collapse there. So this was a great example for me so far in fellowship of looking at how these techniques can be utilized and can avoid a big major open deformity correction. So, but that being all said, the question really in my mind is what are the complications associated with these types of surgeries, and what are the limitations? This was a paper by Dr. Uribe. This was a recent paper, I think, but basically this table was interesting to me because it showed showed some of the thought process about what types of patients can be treated with minimally invasive approaches and which types of patients need more more invasive techniques, more sort of hybrid with a posterior column osteotomies, et cetera. So if you look at these patients on the left, these are like mild compensated patients with low PI-LL mismatch or moderate PI-LL mismatch, and these can be treated, with MIS, even consideration for standalone interbodies. But as you get further along, you need to talk about posterior fixation and facetectomies or even posterior column osteotomies in a more hybrid approach. So it was interesting to learn about sort of the parameters for how to apply these techniques and different approaches. So food for thought. This paper also went through some of the complications from MIS, which showed paresthesias and numbness was between 8 and 42%. 3 to 23% had neurologic weakness. There's also consideration that needs to be made for abdominal wall paresis or lateral incision hernia when you're doing lateral surgery, as well as colonic pseudo obstruction or ileus. So, doing an all posterior approach, obviously that's not an issue. But when you're talking about doing significant work through the abdomen or through the lateral access corridor, you can get these issues more readily. Instrumentation complications, there can be failure subsidence, PJK, or vertebral body fractures, end plate fractures, more commonly. But interestingly, when looking at the literature, MIS has not really been MIS techniques for deformity correction have not really been able to decrease the rate of proximal junctional kyphosis, which to me, doesn't, it's hard to understand why that is, but I think it has to do with, we can get into that in a discussion, but another paper by Dr. Uribe showed 35% in MIS PJK rate, 16% progressed to actual junctional failure. And that's increased with posterior column osteotomies in a hybrid fashion. And then this is a paper by Dr. Eastlack, which, looking at a recent paper looking at, and the ISSG, the paper is looking at early and late reoperation rates with various techniques, MIS techniques, and showing overall reoperation was 27.9 and 33% for circumferential MIS and hybrid techniques. Junctional failures were more common with the hybrid approaches. Pseudoarthrosis and fixation failures were more common with a circumferential MIS, but early reoperations were less than late, and then circumferential MIS demonstrated a less risk of infection and less risk of early reoperation compared to hybrid. So this was a patient that we saw in clinic this week, and I was talking with Dr. Mundis about just the idea of MIS for a patient with a severe deformity. And it got me thinking, what are the limitations, and where is it applicable and where is it not? And so certainly a lot of red flags for this patient. She's 88 years old. She didn't have a DEXA, but her Hounsfield units were 40 at L1. She has a pretty severe coronal plane, pretty significant coronal plane abnormality. And then we don't really know about the curve rigidity, but I think in her probably fairly rigid. So given everything sort of that discussed so far, I'm wondering what people's thoughts are about a patient like this, and what would the crowd say about taking care of a woman like this who's in pretty decent shape. She doesn't appear very fragile. She seems very active and relatively healthy with no cardiac or pulmonary problems. But I'll open it up to the floor to see what people think about this patient.
Well, obviously, deformity is one thing, but patient substrate's another. And we saw her together. She already know my opinion, but I think especially this lady, it's kind of a great example, because I wish you could have the picture of her clinically.
Right.
Because this lady looks like she's 60 years old. She looks incredibly young. One of her parents lived to be in her late 90s. Another one her father died, but she had a grandma that was 100 and some years old. So there's longevity in her family as well, But to me, when someone's, bone quality begins to diminish like this, I think it's a sign of everything else. And so it's a symptom of, this patient's regenerative ability and recovery is likely altered, despite her resilience likely being high. If we looked at her resilience score, that it was super high.
Tough situation.
Yeah, I mean, I'm a 10-foot pole kind of guy in patients like these. I don't know if we meaningfully, make them better, unless you can find an isolated area that seems to be perhaps contributing to the majority of her pain.
So just to open the conversation up a little bit further, if this patient was 60 and had good bone density.
Are you saying like MIS versus open? Is that what you're saying?
Yeah. Yes. I mean, we talked about,
for me,
the
this
levels.
patient has that pretty big thoracolumbar kyphosis. If you believe that the thoracolumbar kyphosis needs to be fixed, then to me this does not end up being an MIS candidate anymore. You can do it hybrid, where you do the bottom MIS and then the top open or something like that. But that's where, for me at least, these TL deformities likely need a bit more work from an open standpoint. Although she looks fused across the TL junction, so
Right.
Hey, Greg,
Yeah.
Greg, would you agree that if it's a rigid deformity, your tendency is to do more open than MIS?
Yeah. Yeah. My tendency, like my current place now, is if they need 4 or more interbodies, I typically go open. Uribe and I know Bob's been involved in some of the discussions. We believe there's a limit to when, like there seems to be a threshold above which the interbodies end up being maybe a little bit more invasive than not. So putting 4 holes in the psoas is a big hit to the patient, especially as it relates to early recovery and things like that. You know, we've all had patients that did fine with it, but I think all had plenty of patients that have struggled in those, early weeks to months in recovering psoas function and stability. And I think, it's hard to parse that out right now without looking at the data, but there's this general sense that, numerous interbodies end up leading to, an invasive, something that is not minimally invasive in that sense. There's sort of this like invasiveness scale is actually important, because it may be that doing 3 approaches, even though they're all small incisions, ends up being more invasive than a single posterior approach with muscle splitting. So that, that's the trade-off is 3 approaches really less invasive than 1.
And then you're probably fracturing as opposed to correcting, right? Because it's such a rigid issue.
Yeah, so super rigid, and yeah, you got to be careful on those for sure. Those can just end up being bad.
That's the comment I was going to make. That Greg made was the degree of invasiveness. I think, just unrelated to this patient, the MIS has been really used in different studies very loosely. And if you look at the MIS definition from 15 years ago, the first cases of MIS for adult spine deformity was presented to SRS was pretty much lateral, that Greg is now talking about. A revision in thought of multiple levels may not be as minimally invasive. So I think it's important to look at the papers when you read to see what they mean by MIS, how much hybrid and how much really what was done. I think is important than just calling it MIS. So I think that's the point, that you have to really look at the papers, what they have done, and be able to compare it with open and other things. But the goal always is to achieve the best results, like open or better. So that's the goal, not just a small incision.
Hey, Rob,
sorry, go ahead.
The first patient that you presented, you mentioned that they went into cardiac arrest with their first surgery. Was that like a medical issue, or was that a surgical issue?
Well, so it was basically during the approach. They called it Takotsuba cardiomyopathy, and postoperatively, so they aborted the surgery, obviously, and postoperatively had an extensive cardiac workup without Dr. Mundus, as far as my understanding, there was no significant cardiac problems that were noted. She had a full workup. She had a Holter monitor for a long time, and they just didn't have a good explanation. She underwent the surgery a year later successfully, minus the increased uptake on the SPECT.
They basically, once they made the incision, I think they may have had like a peritoneal violation or something like that, because the anesthesiologist made mention that once they entered the peritoneum, that's when they saw the big change. And apparently that can happen sometimes with pressure shifts or sympathetic responses or something like that. So, and she had numerous scars on her abdomen, so I know she's had multiple anterior surgeries. So yeah, they said it's like described with this like massive sympathetic response.
So a comment about that surgery. You mentioned, Rob, the name of the surgeon who did that. Did that add anything to our knowledge in this case?
Could you, I'm not sure I understand the question.
Is that this, you mentioned that the surgery was done by someone.
Yes.
Disclosing the name of the surgeon, does it add anything?
Oh, I'm sorry. I don't know. When we're doing the HPI, it was just included. No, it doesn't add anything.
I think we should avoid that.
That's fine. I apologize. When we're doing these in a more open forum now, I think you're right. I didn't, it was not done with any intention or anything, just.
Yeah, no worries. And he actually, and I would in general agree. It's nice just to maintain anonymity.
Yeah, I apologize.
But that surgeon did actually send the patient over to us. So.
Yeah. So I had a question that came up in sort of looking at, if we have a few more minutes looking at this, and I did mention it in the literature discussion, but as far as the PJK rates for MIS or circumferential MIS, my perception of the etiology of PJK is, part of the etiology of it is violation of the posterior ligamentous complex at the top of the construct, and certainly that has been a target for trying to avoid PJK. But then looking at the rates of PJK in MIS, where there's no violation, it's interesting that there's no improvement. So I wondered what people's thoughts were. Certainly overcorrection of sagittal plane parameters in elderly people and everything has been discussed, but I wondered what your thoughts were on that specific aspect of this.
Can you criticize the study?
The study, which one? The Uribe one?
The PJK one, yeah.
Well, I think that there were, I'm not sure what you're getting at. I think that
what did they not, or what did we not consider in discussing?
I think when you have elderly patients that have sagittal imbalance that they're used to, they're compensated in that sort of somewhat compensated in that plane. And then if you're looking at the numbers, PILL mismatch, lordosis, et cetera, and you're just jamming in, these massive lordotic cages and you're fixing those numbers, is that the exact right thing for an elderly person who's really accommodated over decades to being a little bit more forward? So I think, that's my understanding of why you're not really seeing much improvement.
I was thinking more bone density, what's the failure mechanism? Did they report on the failure mechanism? Was it bony? Was it ligamentous? Was it through the disc? So you really need to scrutinize PJK more. It may be that the ligamentous failures aren't as many, but we have more bony failures. Maybe there's a bias in approaching older patients with MIS surgery that have weaker bone than, say, the open group. And maybe those patients that got MIS surgery weren't candidates for an open surgery. And so I think it's on those elements that I'd be like, you've got to take the data with a grain of salt, because it may not be truly comparing apples to apples. And I think that's kind of where I'd say, if you're reading that study, that's where our main limitation was, is saying, this, we're saying this versus that, but if the two groups aren't equal, then is it fair to make those comparisons? And we tried to make them equal in our defense, but we were just missing data to make them truly equal. So bone density data, et cetera.
Thanks, Dr. Mundis. This is Dan. I just have a question or a comment here. And forgive me if I'm ignorant of the literature here, but a lot of the MIS deformity techniques that I've seen have the pedicle screws and the inner body instrumentation ending at the same level. Is there a thought that potentially doing more pedicle screw instrumentation than inner bodies could protect from PJK and having different landing levels and potentially having a so-called softer landing?
That's actually gone both ways in the literature. There's actually a paper that says ending with inner body and percutaneous screws is protective, and then there's others that refute that. The problem, I think the problem again is that the granularity of the data, and most of it's retrospective, right, is going to be the main hamper to making any type of conclusion from it. Because on the one side, you have a more rigid construct, right? So you end with an inner body and screws. That's way more rigid than saying just percutaneous screws, even without a fusion per se. That would be like the softest version of what kind of a landing we have outside of using like bands or something like that. So, to answer your question, it's a gray zone. I think trying to choose your landing spot's important. So, like if you look at this case, we tried to end where the pedicle screws are relatively parallel. It's into a nice transition to the thoracolumbar junction. You're kind of staying below L1 if you can. This is a nice place for trying to do something less invasive and just trying to rebalance the patient versus doing something that involves a lot of correction. If you're doing a substantial amount of correction, then I think you do have to be pretty cautious with your UIV. And in this case, we didn't use iliac fixation. She had monster bites in her S1 and L5, so we didn't feel the need to go all the way down to the pelvis after that. But certainly adding pelvic fixation also makes the construct more rigid and likely puts more pressure at the proximal level. So those are all kind of things that you have to weigh into your decision making. Checking Hounsfeld units, checking DEXA scans, making sure the bone density is okay at the place where you're stopping. And then hopefully these less invasive techniques, and whether it's midline ligament sparing with screws or whether it's just true percutaneous screws, will protect the ligamentous structures. But even then they fail, right?
Mm-hmm.
So good comment, and sorry for not having a completely clear answer for you.
No, I figured the answer probably wasn't out there, but I thought it would be nice to ask.
Yeah.
All right. Thank you,
guys. Well, 7:55. Have a wonderful day and week. And for those in your research meeting, I'll see you guys tomorrow.
Thank you, everybody.
All right.
Thanks, everybody.